Hello friends, welcome to King's Crux, and today's topic of discussion is papilledema. So papilledema is a very important topic in neuro-ophthalmology and we will cover comprehensively in this review. I want to dedicate this lecture to the professor, one of my favorite professors who taught us what papilledema is, Dr. Kausalya ma'am. And we will discuss papilledema in 3 levels of understanding. First level, I will take you through the basics of the topic, because before understanding what papilledema is, you need to understand what causes the papilledema and what are the relevant fundamental principles which you have to understand. And in the second level, I will discuss some case presentations so that you'll have a complete understanding of the practical, the point of view. And in third level, I'll add on some of the details to the disease so that you'll have a complete understanding of the topic. So let's start with level 1. So, what is papilledema? Literally means disc edema, but not all disc edemas are papilledema. Disc edema can be papilledema or it can be something else. So I reserve this topic or we reserve this term papilledema only when it is going to be almost always bilateral, sometimes can be unilateral also. So a bilateral disc edema which occurs due to an increase in the intracranial tension or the increased intracranial pressure. So our concerns are about the rise in intracranial tension and about the disc edema which follows the intracranial tension rise. Right. Now let's start from scratch. We have the optic nerve which has the 4 parts: the intraocular part, the intraorbital part, the intracanalicula part and the intracranial part. And the intraorbital is the longest and the shortest is the intraocular part. This intraocular part of optic nerve is also called as optic nerve head or also called as the optic disc. So the optic disc or optic nerve head has 4 parts because this is the retinal nerve fiber layer which comes and traverses retina, choroid, sclera and goes beyond like this. So it has to travel through retina, choroid and sclera, and as it passes through sclera, it has to pass through the cribriform, the lamina cribrosa of the sclera. So accordingly, we have 4 layers or 4 parts. First is this most superficial surface nerve fiber layer. Then you have the prelaminar, laminar and the retrolaminar areas of optic nerve head. So prelaminar region is our concern right now. And again, you have to see that whatever lies beyond it, so the retrolaminar part of the optic nerve has or is surrounded by the pia, arachnoid and dura, the sheath, the meningeal sheath. And in the subarachnoid space, you can see the CSF flowing through it. So CSF baits optic nerve. So as you can find in this picture, here you can see the CSF which is going to flow in the meningeal sheath, to be exact in the subarachnoid space, thereby it covers the optic nerve. Okay, let's talk about CSF for some time. CSF or cerebrospinal fluid is secreted from the lateral ventricles. It goes to the third ventricle via foramen of Monro, and from third ventricle it goes to the fourth ventricle via the aqueduct of Sylvius. From the aqueduct of Sylvius to the fourth ventricle, and it goes to the subarachnoid space via foramen of Lashka and Magendie. From subarachnoid space, it goes and seeps through the spinal cord and the brain, and finally exits the brain by absorbing through arachnoid villi, and it goes to the venous sinuses. So this is the basic circulation of CSF. So again, in this picture you can see from the lateral ventricle to the third ventricle, third ventricle to the fourth ventricle, to the fourth ventricle to subarachnoid space. And from subarachnoid space it goes to this arachnoid villi, and from there they are going to get drained into superior sagittal sinus. So any problem in this circulation, if there's going to be a space occupying lesion or if it's going to be a venous thrombosis here, as you can see in the superior sagittal sinus, if there's going to be a cerebral venous thrombosis, or without any cause, maybe an idiopathic cause which causes the idiopathic intracranial hypertension, where there's going to be a rise in CSF without any SOL or without any CVTs. Now these 3 conditions are very crucial because these 3 conditions can cause a rise in CSF pressure. As a result, they can cause papilledema. So papilledema occurs because of rise in CSF pressure, because of essentially these three conditions. There are so many other conditions which can cause papilledema, but these three are the most important. So here you have the space occupying lesion, the Pseudotumor cerebri, also called as the Idiopathic Intracranial Hypertension, and you have the venous thrombosis, the CVT. Apart from that, any hemorrhages, meningitis can also lead on to papilledema. And these are some uncommon conditions which can cause papilledema, which we are not concerned right now. What happens when there is a rise in intracranial pressure? Now we can see that here the optic disc is normal. There is no swelling of optic disc because CSF is normal, the pressure is normal, so optic nerve is also normal. But when there's going to be an increase in CSF pressure because of the before mentioned causes, what happens? The optic nerve pressure is going to be high. That is, the optic nerve tissue pressure is going to be high. So when there's going to be a rise in the optic nerve pressure, the axoplasmic transport gets interrupted. This is an optic nerve, and the information has to come from the retina to the optic nerve to the brain, and from the brain to the retina, so as to know what's happening around. So when there's going to be an axoplasmic block, there is going to be axoplasmic stasis, and the disc is going to get swollen. Understand this. This is going to be the optic nerve, which is surrounded by the CSF. So the CSF is going to flow through this part. And here you have two important pressures, the intraocular pressure and the CSF pressure. The CSF pressure is determined by the intracranial pressure. So more the intracranial pressure, more the CSF pressure. What happens there is it's going to compress, so the optic nerve tissue pressure is going to be also raised. Now, there has to be a pressure gradient between IOP and ONTP. It's called as the intra-axonal pressure. IAP. So, the IAP is equal to IOP minus ONTP. So, whenever there is going to be a rise in optic nerve tissue pressure, or it's going to be a reduction in IOP, the IAP is going to have a negative value, or is going to have a reduction. A reduced intra-axonal pressure will cause disc edema by axoplasmic stasis. So let's review again. IAP is equal to IOP minus ONTP. Okay, so a reduction in the IOP or an increase in the ONTP will lead to reduction in the intraaxonal pressure, thereby causing disc swelling. So you have to understand these important values. IOP is always more when compared to ONTP normally. And the CSF pressure is very often asked question in the exams, because CSF pressure can be either 100 to 180 mm of water or 8 to 15 mm of mercury. So when there is going to be a reduction in the intraaxonal pressure, the flow of axoplasm is interrupted, which then causes accumulation and stasis of the axoplasm in the optic nerve head. So as the axoplasm gets stased or gets accumulated, the optic nerve gets swollen. Now this is essentially a hydrostatic, passive, non-inflammatory swelling, and we give the swelling name as the papilledema. And this is what the Hare told us. So it's called as the Hare's theory of papilledema. I hope it's very clear till now. Now let's go for some two case presentations to understand what papilledema or how it will present basically. So we have the first patient, a 25-year-old obese female. I want to add it here. Okay. Now she's complaining of headache, a throbbing headache, which is more in the morning. As the day progresses, it gets reduced. And she gives a very interesting symptom, the transient obscuration of vision, whether it's occasional or just a temporary loss of vision lasting for a few seconds to minutes, which is more so when she is going to have a change in posture, say from sitting to standing, or from lying up to sitting, or even from bending to standing up. She experiences these symptoms of transient obscuration of vision. And she also gives a history of a diplopia, a horizontal double vision. But her vision is normal, her pupils are good reacting light, and she has some specific field defects, which we will come back later. When I see the fundus for this patient, there is a bilateral disc edema. So let us analyze the symptoms for a moment. So we discussed about the headache. We discussed about the transient visual loss which occurs because of a transient ischemia of optic nerve. See, this is very, very important because a transient obscuration of vision can be either unilateral or bilateral. When it's going to be unilateral, think of papilledema. When it's bilateral, also think about papilledema. There are some other causes which are also to be noted when it comes to transient obscuration of vision. Okay, why the patient had diplopia? When there is a rise in the intracranial pressure, there is going to be the herniation of the brainstem which is going to push downwards, and thereby the sixth nerve, that is the abducent nerve's sheath, gets compressed or gets pressure compressed at the petrous tip or the apex of the petrous temporal bone. So thereby the compression of the sixth nerve causes diplopia. Now this is not because of any reasons, this is because of a rise in ICP only, therefore this is a false localizing sign. What is the field effect the patient had? The patient had an enlarged blind spot. Now, why should the patient have an enlarged blind spot? It's because, very simple, the peripapillary retina in this patient went for a compression and detachment. That's why she had enlarged blind spot. As you can see in this picture, this is the normal blind spot and this is the enlarged blind spot. And there is also some visual field constriction also is noted in this picture. Then I obtain a scan for this patient. I take an MRI brain, and MRI brain reveals dilated optic nerve sheath. You can see here. And the optic nerve edema or optic disc edema is noted here. One interesting thing I find here is that in this region, that is where the sella turcica is, where the pituitary gland normally lies, it looks like as if the CSF has kind of covered or eclipsed the pituitary, and pituitary or the sella now appears empty. So it's called as the empty sella sign. So the empty sella sign is a very important sign in idiopathic intracranial hypertension, which is the diagnosis for this patient. Now, one of the most important causes, one of the most important risk factors associated is obesity, as we have in this patient. And very important, some of the important drugs which can be associated with IIH are tetracyclines and vitamin A. Very often asked question again. So what is the criteria to diagnose idiopathic intracranial hypertension? That we go for the so-called Danby's criteria. So what this criteria says is that the patient should have the symptoms and signs of rise in intracranial pressure, number one. Number two, the patient should have a rise in intracranial pressure which should be documented by lumbar puncture. And whatever CSF you obtain from the lumbar puncture should have a normal composition. And there should not be any evidence of any hydrocephalus or a space occupying lesion. Okay, and again there should be no other cause of intracranial hypertension. So IIH is essentially a diagnosis of exclusion, to be precise. So to treat the IIH, since in our patient the visual loss was not there, we went and treated with acetazolamide, which is a diuretic, and we advise for weight reduction also. When the patient is going to have a mild visual loss, again we can try using diuretics, but when the visual loss is going to be severe or progressive, we opt for optic nerve sheath decompression, which is very, very important. Because when we are going to stab the optic nerve sheath, we're going to release the CSF and thereby we relieve the pressure of the patient's optic nerve. Also, IV steroids are also another important medical treatment, and if everything fails, we go for this lumbar-peritoneal shunt for failed ONST or for intractable headache. So this was the fundus picture of the patient before treatment, and this was after treatment with acetazolamide. Now that's with the first case, the patient who was diagnosed with IIH. Now we have a second interesting case where a 7-year-old kid came to the OPD with a swelling of the behind of the ear, the mastoid region of the ear. So there was a left ear pain and swelling. There was fever, and again the patient had a diplopia complaints. His vision was fine, his pupils were normal. Fundus also had a bilateral disc edema similar to the previous one. So what are we missing here? So we have a connection with the ear and the eye here. When we obtain the scans, MRI and MRV were obtained, and we can find that there is an enhancement at the mastoid region suggestive of mastoiditis. So there's an infective foci is there. And because of this infective foci, what has happened is that when we attain the MR venogram, you can see there's absence of flow. You can see the absence of flow in this region. There is no flow here when compared to this side. So the left side, there is an absence of flow in the sagittal sinuses as well as the jugular vein also, suggestive of a cerebro-venous thrombosis. So the diagnosis was cerebral venous thrombosis, or CVT, which is secondary to infections. As you can see, CVT can be because of so many conditions, most commonly because of an infection, or it can be because of any bleeding disorders, or it can also be because of bleeding, it's going to be clotting disorders. Even it can be because of some drugs also. Yes, so we discuss two important cases on this papilledema, and we will take on through level 3. We'll add some more details to papilledema now. There are 4 stages of papilledema: early, established, chronic, and the 4th is the final optic atrophy stage. So these are the 4 stages here. This is going to be the early stage. This is going to be the established stage. This is going to be the chronic, and this is going to be the optic atrophy stage. Now, in the early papilledema, the changes are very subtle. They are not of much of unless we look for what we want, we might even miss the findings. So it's going to be some subtle changes. Mainly, there's going to be some hyperemia of the disc. There's just going to be hyperemia of the disc. The margins are blurred, and the disc appears elevated. And there is going to be occasional hemorrhages here and there, some kind of or very minimal tortuosity of vessels. So these are the features of early papilledema. But in the established or acute papilledema, the features are very marked and very conspicuous. You can see some marked hyperemia here. There's a marked hyperemia. Markedness is going to be severe blurring. The blurring is there. The elevation is there. And not just that, there's going to be the obliteration of the physiological cup. The physiological cup gets filled. The cup gets filled up by the exudates, and it's going to be obliterated. And there's going to be some flame-shaped hemorrhages here. The flame-shaped hemorrhages are there. And you can find some of the, you can see the hard exudates here. You can find the hard exudates. Some of the cotton wool spots are also to be noted. Okay. And you can see that the vessels are very tortuous here. So in established acute papilledema, the disease is very severe in the sense it is, but still the visual acuity is maintained most of the time. So the patient will have a normal visual acuity even in this stage, and also in this stage. Okay, so this established or acute papilledema will have normal visual acuity, but again the fundus features are very prominent. Even the retina might be involved in this patient. There might be macular edema, there might be macular hemorrhage also as well. When the disc goes for a chronicity, as in a chronic papilledema, the hemorrhages will disappear. There is no hemorrhage. The exudates will disappear. No exudates. Okay, and edema becomes consolidated. It's called so-called the consolidated edema. Consolidated edema, and the disc will appear elevated like a cork, so-called the champagne cork appearance in chronic papilledema. Okay, so it's going to be a pale disc with an elevated disc. Okay, this is called as the consolidated edema or chronic papilledema. Here, there's going to be a reduction in the vision. So the chronic papilledema will again go for a post-papilledematous optic atrophy unless treated. So what happens here is the optic disc becomes glyosed. Okay, there's going to be complete atrophy of the the nerve fibers. Okay, it goes for the so-called gray or dirty white pallor. This is essentially it's a secondary optic atrophy. Now again here there's going to be reduction vision, obviously. So we have discussed these 4 important. That's the early papilledema, where you have only subtle changes, very subtle. very minor changes. The established papilledema, where you have very marked changes. You can see in the acute papilledema, there's going to be this obscuration of vessels. The vessels are obscured. You can see the vessels coming all the way from here, but you cannot see the vessels here. Only vessels start coming from here. That's a very important sign, because the retinal nerve fiber, which is adjacent to the optic disc, kind of gets elevated, thereby it obscures the retinal vessels there. The chronic papilledema, the post-papilledematous optic atrophy. Spontaneous venous pulsations. The spontaneous venous pulsations are very, very important feature, because they're nothing but some venous pulsations which you can see at the edge of the cup. At the edge of the cup, you can see the vein getting pulsating. This spontaneous venous pulsation is normally present in 80% of normal people, but it is also absent in 20%. The significance is that when you have presence of spontaneous venous pulsation, it means that the intracranial pressure is less. Okay, but again, it can be absent in 20% of normal people. This SVP is absent in papilledema. So there should not be confusion. SVP is absent in papilledema. SVP is absent in 20% of normal people, which means that presence of spontaneous venous pulsation will rule out papilledema. When I see an SVP, it is not a papilledema. But what looks like a papilledema, with SVP, it is a pseudopapilledema, which we'll discuss about in a few moments of time. So this is very, very important, the spontaneous venous pulsation. Now, this table clearly tells the differences between acute and chronic papilledema. See, the features which are common for both: the disc is elevated, the veins are distended, there is obscuration of disc margin, there is absence of spontaneous venous pulsation. Okay, there is the features common to both acute and chronic, but only acute will have a hyperemia, cotton wool spots, and peripapillary hemorrhages, and only chronic will have the champagne cork appearance and overlying gliosis, disc atrophy as it progresses later. Okay, what are the various retinal changes associated with papilledema? Very commonly you can find some macular changes, as in macular exudates, which is going to spread in the form of a star called as the macular star, macular edema, and macular hemorrhages. Uncommonly, we might have a subretinal neovascular membrane, can also be a possibility. So, to just go back and reflect, what can be the reasons for defective vision papilledema? As I already told, chronic papilledema and optic atrophy are two important reasons why we have defective vision, and not just that, any macular pathology also can lead to defective vision papilledema. Now, this is a FRISEN scale, which is a scale which is used to grade papilledema, and you just need to know that there are grades 0 to 5, and I don't think there is a need to remember what the grades are. Yes. See, as I mentioned in the first place, not all disc edemas are papilledema, but all papilledemas are disc edemas. Okay, let's make that as clear as possible. So there are many causes or many differential diagnoses which you can give for a swollen optic disc or an edematous optic disc, and the most common of them being papilledema. And not just that, you have optic neuritis, you have AION, and you have pseudopapilledema. I think you heard it before. And also CRVO is also another cause, and diabetic papillopathy is also another reason. And again, very, very important, an ocular hypotony, reduction in the IOP, can also cause a disc swelling. And again, very important, a malignant hypertension can also cause disc swelling. Now, with these points in mind, let us discuss something further. A patient is presenting me with optic neuritis versus a patient presenting to me with papilledema. What are the differences? See, optic neuritis, to be more precise here, the type is papillitis. The patient complains of pain. That's a painful, sudden, defective vision, which is unilateral mostly. Okay, sudden defective vision. There's going to be RAPD is going to be positive. The relative afferent pupillary defect is going to be positive, which means the optic nerve is inflamed. and there's going to be just a moderate swelling of the disc. But whereas in papilledema, it is going to be a bilateral condition almost always. There are conditions which might have unilateral papilledema. The onset is insidious. There's a gradual reduction in vision, and the swelling is marked. There's going to be a concentric contraction of the visual field. There's going to be enlarged blind spot as well. Let's talk about pseudopapilledema for now. You're talking about this for some time. Now, what are the various causes for pseudopapilledema? Now, these are not edemas. They look like an edema, but they are not in fact. One important such condition is optic disc drusen, nothing but some calcium deposits on the disc. Okay, here you can see there is no obscuration of vessels. The vessels are freely moving. There is no obscuration. There is no impediment in the flow, and you can see in the scan, it just clearly shows some calcified spots can be noted in CT scan here. The second differential is hypermetropia, very common, very common, because very often when we might see some patients which might look like a disc edema, but in fact looks like a tilted disc. There's going to be a tilting of the disc. The disc is tilted, the disc is small. You have to always think about hypermetropia. And also again, myelinated nerve fibers is another differential diagnosis. You can see the myelinated nerve fibers here. This may mimic like papilledema, but in fact they are not papilledema, they are pseudopapilledema. One very interesting feature is Foster-Kennedy syndrome. Now, as I told you previously, most often papilledemas are always bilateral, but at times they can be unilateral as well. And this is one of the conditions where you have a unilateral papilledema. Now, what is this? In this picture, you can see there's going to be a tumor in the frontal lobe. There's a frontal lobe tumor on the right side. This is the right side, this is the left side. So, a tumor on the right side is going to cause an optic atrophy on the right side, whereas on the left side, on the opposite side, it has caused a papilledema. So, this is what we call as the Foster-Kennedy syndrome. There is a tumor on the right side which causes a unilateral optic atrophy and a contralateral papilledema. I remember seeing a patient who was 18-year-old. He came to the OPD which complains of headache, defective vision, and there was a gross visual disturbance. He was able to just count fingers only. When I saw the disc, I had a look at this picture. You can see that's a very gross, very marked and very very dangerous looking eye. The discs were blurred in margins. You can see lots of macula getting involved. There you can see the macular stars. You can see the cotton wool spots, which is a very important feature. Then I asked to check the blood pressure. The blood pressure was 220/140. This patient. So immediately they was referred to the physician, and the patient was found to have glomerulonephritis. So this is what you have to understand, that you should never ever underestimate the power of the common symptom headache. So the practice pearls are always look for the fundus in all headaches. Number 2, not all disc edemas are papilledema. We reserve the term papilledema only when there is a rise in intracranial tension. And you should rule out other causes of disc swelling. You should rule out the other causes of pseudoedema, pseudopapilledema. And always check for BP to rule out malignant hypertension. And always do neuroimaging to find out the cause of papilledema. Is it an SOL, or is it a CVT, or is it a hemorrhage, or even is it an IIH? So this ends the discussion on papilledema. Hope you liked it. Cheers. Thank you so much for listening.